Okay, thank you everyone for being with us. Good evening. Before we begin, I want to say that while the corona pandemic remains a very large part of our lives, and that is going to be the topic of tonight's discussion, we cannot ignore what is literally happening outside of our homes as we speak right now. We strongly stand up against racial injustice and pray for the safety of our country. We wish a refuah shlema to those who are ill and express our condolences to all those who have lost loved ones during this difficult time. We stand together. Tonight, we are pleased to present Keeping Up with the Curve Part 2, which is the result of so many responses to the last Zoom led by our very own Dr. Sarah Schlesinger Hirschfeld. Dr. Schlesinger Hirschfeld is Associate Professor of Clinical Investigation at the Rockefeller University and the Chair of the Institutional Review Board and Senior Physician at the Rockefeller University Hospital. To us, though, she is most notably known as Jacob Hirschfeld's mommy. Our moderator tonight, Rabbi Chaim Steinmetz, is the senior rabbi of KJ and someone who shares so much wisdom and knowledge and a wealth of topics. So please, I remind everyone that at the bottom of your screens there is a Q&A button, and while you cannot be seen or heard, you can be writing a question, and Dr. Schlesinger Hirschfeld will be responding to as many of them as she can. We actually did elicit questions before the evening, and Rabbi Steinmetz will be posing many of those questions to Dr. Schlesinger Hirschfeld as part of the presentation this evening. Again, for joining us.
Okay, thank you so much, Kenny. I also just have to echo Kenny's remarks. Clearly, we've had this planned. It is
Rabbi Steinmetz.
Can you hear me? Okay, so I just want to echo Kenny's remarks. I mean, clearly we had this planned. The coronavirus is still a significant issue and will be a significant issue for a long time. But I know that we are all terribly shaken. First by the murder of George Floyd, and then of course by the reaction this past week. And we are praying. We are praying for peace, and we are praying for harmony, and we are praying for an end of human hatred. With that prayer, we turn to another area that we've been so concerned about, in which we are not just praying as in all areas, but we are also doing our best to counter it and to find the best way to live. And it is, again, my honor to be here with Dr. Sarah Schlesinger, and I know Kenny introduced her. I want to just add a couple of points. I know many of you were here with last time, but I just want to, if you don't mind, I'm going to add a couple of points. I mean, first I want to note, I mean, aside from being a professor at Rockefeller University and the chair of the Institutional Review Board, she, as a 17-year-old, worked in the lab of Dr. Ralph Steinman and Dr. Danville Kahn, and that was a remarkable experience, particularly because Dr. Steinman ended up getting a Nobel Prize. And this was a powerful experience, and I know that you had a lifelong relationship with him, and that you have also have an exceptional experience, particularly with the development of vaccines, and having spent 20 years on the HIV vaccine and being the primary investigator on 11 different vaccine studies, and being someone who sits on the board of multiple corporations, and most significantly to come back to something that touched me last time, and I'm going to mention it again because this is what being a role model is all about. She is a third generation woman physician. Her mother and her grandmother were both physicians. And even though perhaps today it's not as remarkable as in the past 2 generations ago was extremely rare. And it teaches us about the potential that women have. And it was a potential that wasn't realized for so many years. And so Sarah is married to Ellie Hirschfeld. Together they have 10 children and they have 3 granddaughters. And it is a pleasure to have Sarah with us this evening. Welcome, Sarah.
Thank you, Rabbi, and thank you, Kenny, very much. I just want to make one minor change. It's actually my aunt who's the physician. My mom is a physical therapist and my aunt is a physician. She's actually it's quite all right. She's the first person who ever took me into clinic, even before I got into the lab. So, the power of a role model and, is not to be underestimated. Thank you very much. And thank you to everybody who was so interested and so enthusiastic the last time we spoke. I know that we're all struggling with this, but when the rabbi and I were discussing what we would talk about tonight, I was explaining to him that I've spent my life studying antiviral immunity, how we make an immune response to viruses, particularly HIV, but several others, and how we induce that with a vaccine. And frankly, for most of my life, that hasn't been of all that much interest to everybody else. It was an arcane area of study. And now, of course, it seems top of mind and of great use. And so I'm both honored and frankly, really pleased to be able to help in any way that I can. And one of the things that's so challenging about this virus is it's brand new. So 6 months ago, nobody knew anything about this particular coronavirus. There is information about other coronaviruses, but this virus, what's called SARS-CoV-2, was unknown to us. So the absolute incredible growth of the understanding of the virus and what we need to do to combat it has been really inspiring to me. There has been a global kind of cooperation and outpouring of everybody in science sort of offering everything they have, which is inspiring and in the end will carry us through. But for right now, we are awaiting the vaccine and we are awaiting an effective therapy. And while we do that, there are a lot of things we can do. And again, some of them are well understood, but many of them and many of the details of how this virus is special and what protects us and what we don't have to do. I mean, when we talked 2 weeks ago, I was afraid of my groceries. I was spraying them down and I was putting them in quarantine and I had this whole sort of OCD project with them. Now it's become clear that it's really unlikely that the virus is spread by surfaces, particularly paper and fabric, which is great because now I'm not afraid of my groceries anymore. I still wash my hands. I'm still careful, but not in quite the same way that I was, because it's really hard to be vigilant about all these things. And so as we learn what we need to do and what we don't need to do, we need to be flexible in adapting. So I'm delighted to be here. And Rabbi, I know we have more questions that we're going to get to.
We've got I have 8 topics that I want to get to. Okay. And I know that there are questions.
But I don't know about that fast.
Yeah, well, we'll go through and I have questions already popping up in the Q&A. But when I like going from the bad news to the good news. So let's start with the bad news and talk about some of the areas which we need to be aware of and places in which one can get the virus. So I wanted to start, maybe we could do with, well, let's do with one at a time. Let's start talking about super spreader events and what they are and how that impacts us as a community, as a synagogue, as a school, and what that means for all of us.
Okay, so that's a great question. And I wanted to mention, and I'm going to send the links. I hadn't even really seen this when we spoke earlier, but there are 2 articles in the New York Times, one called What We Know and one called What We Don't Know. And they each have 6 topics. And I think that they're pretty good. They're doing a lovely job of covering it. Their science writers are good. I don't always agree, but I think that in terms of what we know and what we don't know, this is a pretty good way to look at it. And what we know about super spreader events is that there are these events that have been identified where a single individual is in a group of people and the virus just goes like wildfire. And so the best characterized one that I know and the one with which I'm the most familiar was a super spreader event in a mega church in Seoul, Korea. And from what I've read, the great preponderance, around 70% of the infections in Seoul, Korea, can be genetically linked, if you do the genome of the virus, to that single individual, which is just an astronomical number of events. So if you think about it, the virus is spreading all the time, any virus is. And most of the time it's not successful. Most of the time, it goes and it doesn't take hold. And in fact, the first woman who came back from Iran, who was the first person in New York to be infected, her virus didn't infect anybody else. She knew what she likely had. She's a physician, and she quarantined herself immediately. She wore gloves and a mask, and there has been, to my understanding, no subsequent viruses linked to hers. Other individuals, like this woman in Seoul, Korea, and there was also a case that we discussed last time in Seattle, in a choir, an individual spreads their virus to a large number of people at the same time. And this is called the super spreader event. The one with which we're probably the most familiar is the one that kicked off the epidemic in our community, the lawyer in New Rochelle, who I believe went to a bar mitzvah and a funeral and infected hundreds of people. And why this happens with this virus is not well understood. Whether there's something special about these individuals, or if it's just bad luck and a confluence of conditions. So a person who is asymptomatic or minorly symptomatic and well enough to go to an event, on the curve of viral replication in their mucosal surfaces, in their nose and mouth, where there's just buckets and buckets of virus, and then in an environment where they're there for a long time. So one of the variables is time. So it's very unlikely, as anxious as I get walking up Park Avenue, if somebody walks by you without a mask, it's especially outside, it's extremely unlikely you're going to transmit. As I understand it, there's only one well-documented case of transmission outside, and that was in Wuhan early on in the epidemic. So it appears that being outside and again, we don't know the reasons. These are observations that are being made, and I can sort of figure backwards that light and air and wind and all of that have a lot to do with it. But that's my conjecture. The observation is there's very little transmission outside. So if you walk by somebody outside, it's very unlikely they're going to transmit to you, even if they have the virus, even if they're sneezing. I mean, maybe if they sneeze directly on you and then you touch it, you can come up with a scenario where you'll get it, but it's not likely. On the other hand, if you're sitting in an enclosed space with somebody who has a high viral burden in their respiratory tract over a long period of time, like a Shabbos morning service, and they're not even coughing and sneezing, but speaking and singing, those are the kind of conditions that can lead to a super spreader event. Other colleagues of mine, this is not my particular area of expertise, but are studying this, exactly what is going on, and if there's something special either about the immune system of these people. It doesn't appear to be that there's something special about the viruses, at least as far as I've read, but there may be, but it doesn't appear so. So the observation are these events occur. The conditions that seem to either cause them or strongly contribute to them are being inside, a significant amount of time, greater than 15 minutes, usually greater than half an hour, close proximity, and speaking and singing. So those are the things that we know. What we don't know.
You're describing shul, unfortunately.
Unfortunately.
That's one of the things that really worries me, and that is that, how do you mitigate those risks in a shul? But when you talk about the super spreader, you're talking about prolonged exposure. And maybe if you could explain that just to drop more, because in other words, as we were talking about today, in other words, it's not just that there's more of a chance that you might be touched by the virus, but also the amount of virus that you'll
exactly.
be ingesting.
And that's another relatively new observation, and it's something that I had been hypothesizing about for a while, but now there's actually data about it. And I always love it when then there's actually data. What we call it hand waving, when we just say what we think. And I'm always a little bit reticent to do that. So some viruses are characterized by what's called a dose effect, and others are not. The one that is prototypically or typically known to have a dose effect is chickenpox. So before the chickenpox vaccine, the first child in a family often got a less serious case of chickenpox than the second child, because the first child would pick it up at school or at a birthday party or at a friend's house, and then come home, and the siblings who were living with them and, you know, sharing a bathroom and maybe sharing a bedroom got a higher dose of the virus and would typically get sicker. And there is now pretty good evidence that this virus, there's a dose effect with this virus. And that's why many of the healthcare workers, many of the young people who've gotten very sick and who've died have been healthcare workers, because they're getting exposed in their occupational exposure and, you know, in intubating people and caring for them, and nurses particularly, you know, being exposed to secretions, they get a very large dose of the virus. And, you know, it's additive, right? You're sitting with somebody, they breathe on you once, you know, you get, I don't know, you know, 1,000 particles. They breathe on you twice, you have 3,000, you know, and it goes up very quickly. And so the time is probably a marker for actual dose of the virus. And the thing about it is, and so what can you do? How can you interrupt this? You know, there are many things that can be done, and none of them are perfect. You know, I mean, the only thing that's perfect is to stay home in your own house and not have contact with anybody else, which a lot of us have been sort of doing, and it really works. I mean, if you look at the curves, quarantine works beautifully. I mean, you know, it's been since the 15th century in Venice. You know, you keep people apart, they don't spread disease to one another. But that's not a long-term solution, and it's not even a sort of intermediate-term solution, which is what we're looking at. And this is just something that I always have to remind myself of, that this is going to end, and it's likely going to end. I don't know if it's a year and a half, 2 years, if we're lucky, 6 months, but it will be over. We will look back on this. So we don't need to have a new normal that's going to last for the rest of our lives. We need to be very conservative and careful and protect ourselves, our loved ones, and our community during this interim period while we're awaiting a vaccine and an effective therapy. And the things that we can do to accomplish that are many, and none of them works perfectly, except staying inside, which we've already decided we can't do. One of the things that works the best, and the statistics associated with this, again, I'm not entirely comfortable with them, but this is what's published, and they say it reduces the infectivity rate by half, and that is wearing a mask. And I think one of the great tragedies of the epidemic in New York and in the US is our failure to understand that and the messaging around it. Because in countries like in Japan and in Singapore, where mask wearing is common, and people wore them before this and they wear them to prevent other respiratory diseases, the epidemics have looked nothing like what we've experienced here, nor have the death rates. Because even if you do get sick, again, you've reduced the amount of virus to which you're exposed. So if you think about it as trying to reduce the amount of virus to which you're exposed with all of these various things to interrupt the chain of transmission, a mask is the best thing. It covers your nose and mouth. So if you're transmitting virus, it stays in there, but it also protects you from bringing virus into your nose and mouth. Now you also have to not touch your face, which is, you know, it's like saying, don't think of the elephant in the room. You know, don't touch your face. It's hard. These things are hard to do. I mean, I don't know how many of you have been trying them, but they're not simple.
I know.
If they work,
you feel like you have to tie your hands down.
I know. I've been wearing things with pockets. I put my hands in my pockets, and then I'm like going like this. I have glasses. You know, I think, is it better to wear glasses or contact lenses, which I don't even have? But then I think I'm going to touch the inside of my eyes, which is worse. So, you know, we all have to work these things out for ourselves, but wear a mask and wear it properly. And that's the thing. Again, we discussed this. I don't think we are going to be able to reopen shul or school without conscientious and consistent mask wearing. And it's like any of these prophylactic things, if you don't do it right every time, it kind of doesn't count. And you see people out on the street. I mean, we've all been in Central Park, and it's down around your chin, it's down over by your ear, it's, and it's okay if there's nobody around you to take it down. But when somebody comes, you got to get it right up, and you got to cover your whole nose and mouth. It drives me crazy. I see the commentators on television with the mask, and it's under here. Like, what does that even do for? So I think that,
the nose is the main area. That's the whole point. That's right? Where it resides.
Right. So don't even bother. It's a false sense of security. And so I feel as though we need to really figure out how to do this and do it conscientiously and comfortably. And look, nobody likes it. And as it gets hotter, it's going to be less pleasant. But it is the single most effective way to avoid transmitting the virus or getting infected by it. Staying 6 feet apart, and probably outside it doesn't even need to be 6 feet apart, but 6 feet apart is a safe distance, is great. But if you have a mask, if you get too close, you're okay. So this is now getting to what we were talking about earlier, Rabbi, about harm reduction. And harm reduction is this principle that was a public health principle that was actually introduced for the treatment of addictive diseases. So if you don't have a cure, if you don't have a silver bullet to end something, how do you address it? And this principle, which I really love because it's so practical, and as the rabbi said, I'm the mother of an awful lot of children, and mostly boys, and I'm a very practical person at the end of the day, even at the beginning of the day. I have to be, as most of us who are mothers are. And so you have to do what you can do. And if you do multiple things, you start, you can reduce. So if you wear a mask, you reduce transmission by 50%. If you wash your hands, you reduce transmission. But that's really good hand washing. That's singing happy birthday 2 times, front and back, nails, right, interleaving, under the fingernails, which, it's hard to do. And try getting a 9-year-old boy to do that. I mean, we've done it, but it's tough. And I keep saying to Ellie, if he were 6, I don't know what I'd be doing. And, we have a school and a shul full of small children. They are vectors. I always say they make you believe in spontaneous generation, which is the theory that germs just arise out of the earth, de novo, because they're always getting sick. They're infecting each other because their hygiene is bad. That's just how little kids are. So how do we deal with that? So there's wearing masks. There's hand washing. What's easier in shul is absolutely no handshaking, no hugging, as much as it's wonderful to hug and kiss one another, for the foreseeable future, I fear, unless you're living with somebody, unless it's your immediate family, it's best not to do that.
Right, and I just want to sort of throw in my own sort of analogy, because this is what rabbis do. This idea of harm reduction, which, the 3 primary things is masks and social distancing and hand washing. But the idea of harm reduction is really the idea of slicing a salami, cutting it to the point where it is extremely manageable. And if you do all of these things, and then maybe we'll add in having an open air minyanim and all of these sort of elements will allow us to reduce the risk to the point where we consider it to be normal and manageable. And that's why I think that's the roadmap to reopening until, of course, we get to that silver bullet that we're hoping to get to. And as is usual, I'm holding it to the end.
Yeah, I want to keep
everybody on. We have people here, but I want to keep them on till the end.
Right, something to look forward to.
Right, so we spoke about super spreaders, and we spoke about harm reduction, and we spoke about prolonged exposure. So the next thing I want to talk a little bit about, and maybe it's sort of very straight up, but vulnerable populations, who's vulnerable?
Absolutely.
And what should they be thinking about, and what should they be doing?
So before we get to that, I just want to add a couple of other of the harm reduction measures. One is wearing gloves. So you have to be really careful with the gloves that they don't give you a false sense of security. You still have to wash your hands really well. But even though I'm not afraid of my groceries anymore, the elevator buttons and the steel still seems to be a surface on which the virus lives. So when I go out, I wear gloves. And it also helps to remind me to keep my hands off my face. So that's another thing that I think is helpful. And what you mentioned, and I don't want to dwell on this, but I think it's super important. I mentioned it last time, the idea of light and air. which have been known, since the time of Hippocrates and by Maimonides to fight all sorts of infectious diseases. And there's all kinds of mechanisms by which they do it, but there's really good evidence now that even just opening a window in a room reduces transmission. Because what happens is when somebody speaks, as I am, I'm a talker, as you all kind of can tell, out it comes. And there are two size droplets. There are the bigger droplets and there are the smaller droplets. The bigger droplets contain more virus and they go to the ground, but they don't go to the ground right away. But if you have a window open and there's negative pressure, they apparently fall to the ground much faster. I mean, there are people who are physicists and bioengineers who are doing experiments. So keeping a window open, I mean, an open air is perfect. I really, even though I wear a mask and now I'm wearing a face protector. I ordered some from eBay, like you see the
right, the clear,
right,
yeah.
There's no data on that, but I figure how can it hurt? You're wearing a mask, gloves, you're careful, you wash your hands. I'm still doing all that outside. I don't think being outside is really a tremendous risk. Inside is a much bigger risk, which gets to the challenge that the summer is going to be better because we're outside more. So there are viruses that are called summer viruses, and there are viruses that are called winter viruses. Flu and coronavirus are winter viruses. They thrive in cold, dry air. They tend to degrade in hot and humid conditions. There are other viruses that have the reverse effect, and it has to do with their membranes and the lipids, but it's a topic for another day. But suffice it to say, coronaviruses are less transmissible in hot weather. There was some hope at the beginning that the heat would just completely get rid of it, as it did for SARS-1, which was the SARS-1 in China. When it got to be April or May, it just went away and it never came back. There will likely be some diminishment. It's not going to go away completely, but it's going to be less. The transmission's going to be less. People are probably going to get less sick because they're getting less of a dose. But then when it gets cold again in the fall, and people hypothesize that this may have less to do with the virus than it does with people's behavior, that you're just outside more, schools aren't in session, not that our schools have been in session, people aren't close together. I don't know which of those factors is the case, but I will tell you that it is almost certainly going to get worse in the fall. So in some ways, we have a little bit of a respite now to prepare for the fall. So, and you can have, as you say, we were talking, you could have a minion on the roof. In December, it's unlikely people are going to want to come to a minion on the roof. So I think that opening of windows, again, a small thing, can really go a long way. So I just wanted to add that one in. And cleaning, good cleaning of surfaces. That's it.
Oh yeah, the cleaning is really, really important. And actually, going back to that discussion about, we mentioned this on the phone, singing and speaking, and we mentioned shofar because shofar
I was just going to say,
really
let's not forget the
mother
shofar
of all of those saliva spreading events. In other words, we don't visibly see it, but of course, speaking and singing really does spread saliva, and the shofar would probably be the worst of them all. And we are starting to sort of think about how do you do the shofar in a way that you protect the people around it, so that it doesn't in any way create a spread. Obviously, you would test the person who's sounding the shofar, but at the same time, you can't always rely on tests. We haven't gotten to testing yet.
That's all.
And we'd have to protect that as well.
Right, but as I mentioned to you, our Jacob, who's 9, is a really good shofar blower for reasons that are kind of a mystery. And whenever we have a shofar in the living room, and he likes to do it for a lot of occasions. Some of you out there who've been in our home have probably heard it because he likes to do it a lot. There's spit everywhere. I don't mean to be indelicate.
That's what it is. When you blow the shofar, you're cleaning it on the inside, the outside, always. Yes.
Right, and so I think, as we discussed, there's got to be a special attention to that. The other thing is, people, we're not going to be able to have siddurim. Probably the virus doesn't live long on surfaces, but people should bring their own, keep custody of them, and bring them home. All of these sort of small measures will add up. So that's, and again, we've discussed this, and we will all be discussing this, on and on in our own individual lives, the things that we can do and layer them, as you said, like slicing the salami, one upon each other to get to a place where the risk is acceptable. The other thing that we failed to mention when we talked, and that's really good, is the fewer people in the community who are infected, the lower the risk is. So in the middle of April or the beginning of April, when a large number of people were infected, the likelihood that somebody who was spitting in the air or speaking to you was infected was much greater than now, where the transmission rate is going down. So, I mean, this gets back to, for those of you who were on the last call, the idea of R naught, or R with a subscript 0, the number of people to whom any one person infects. And if it goes over 1, you have a growing epidemic. And if it comes under 1, the epidemic is coming down. And it feeds on itself. So the fewer people who have it, the fewer people will get it. So that's also something that's really good. One of the things that worries me so much about these demonstrations, you know, and I share the sentiments that both Kenny and the rabbi expressed, are, you know, people are out there, they're body to body, they're unmasked, there's no hand washing.
And they're shouting, that's really.
And they're shouting and chanting, and you know, and this is a segue into what you asked about vulnerable populations. So again, we are learning about this virus every day. And I can't tell you, you know, for those of you who are physicians and scientists, and I know there are many, and I was delighted. I actually heard from somebody the last time who's in our community, who's a vet who worked on dendritic cells in her training. So Ralph Steinman, my mentor, discovered dendritic cells, and they are at the core of my interest in immunology. So I know there are many very experienced and expert people out there. And, you know, this is just a terrible, terrible setup. You know, and we're just getting control of the epidemic, and now to see people put each other at risk. Oh, and what I meant to say was that, you know, if you read the scientific literature, the medical literature, and you get up in the morning and you know, we get these sort of digests of what was published overnight, there are new papers every day, every day. People are working all the time, and they're publishing, preprints are coming out. So there's an immense amount of information coming out. And one of the things that's become clear is that people are not vulnerable in the same way. And we've all seen this in our own experience. There are people, I mean, forgive me, Kenny, I think you've been very open that you were ill and it was unpleasant, I'm sure, and then you got better. There are a lot of people who've had that experience. Most people have had that experience. And then there are other people in our community, some very dear friends of ours, who have gotten ill and who've been extremely sick, who've had, you know, long hospitalizations in the ICU, some who've recovered and some who haven't. And that's, you know, the cruelty to this is that it seems in some ways there's no predicting, but in some ways there is predicting. And so if you look at the conditions that make people more vulnerable, and again, this is the same kind of thing as what I said earlier. These are observations of what's really happening. We can hypothesize back as to why, but we don't know that for sure. The observations that we see is that older people are disproportionately affected than younger people. Now, it doesn't mean that everybody who's old, who gets this older, is going to die. But with each increasing decade of life, when you get past 50, the morbidity, which means how people get seriously ill or severe disease, and mortality increase. And, you know, this is part of the reason we've seen these horrible tragedies in nursing homes where the virus has spread and, you know, thousands of people have died. But again, sometimes you see somebody in a nursing home who's 103 and lived through the Spanish flu epidemic and survived. So it's not 100%. But there's no question, people like me who are 60 and over are at higher risk. And once you get to be 70 and over, you're at even higher risk. Once you get to be 80 and over, you're at super high risk. You know, my mother, who I think is listening, and I have had a little bit of tension because I keep telling her, you just have to stay home. And she is, but it's hard. mean, it's really hard. Fortunately, she has a lovely house and outdoor space. I'm like, it's just not worth it, because all of these decisions are decisions about risk. So is the risk worth the benefit? Is what you're going to do so important that the consequences of it are worth it? So for instance, one of our dear friends, Dr. Sidney Mell, who many of you know, was just a wonderful, wonderful man who passed away last week. I think last week.
Yes.
I've been mostly last week. He was seeing his patients. He was a cardiologist, and I get goosebumps. He did what we all do. He saw his patients.
Serving the way he's supposed to serve, and unfortunately, that's one of the questions that keeps popping up is about health care workers, because you mentioned them.
Right, and healthcare workers
they are under.
Exactly, are a particular risk, again, because they're contacting many people who are infected and in higher doses, and that's why the PPE is such an important thing, the right personal protective equipment, because it works. It really does, and fortunately that crisis seems to have been resolved. But the things that people want to do, I have 4 sons, 4 older sons from my first marriage who I dearly love, and I haven't seen them. Not because I typically see them multiple times a week. They're here for Shabbos dinner. I have lunch with them. I have breakfast with them. They're fortunately in New York, and I see them regularly. We haven't seen each other. We talk, we Zoom, we haven't seen each other. And that's really hard. I haven't seen my mother. It's really hard. But the risk is so great that, it's in my mind, and we all have to make our own decisions. And one of the things that's interesting to me is seeing how people make these risk analysis, which is effectively what it is. And you can certainly do things that reduce the risk. And so, one of the things that I've decided, Ellie and I've decided, is that we will go and see my boys outside, in the park. If you're outside and you're more than 6 feet away and you're wearing a mask, it's fine. But that, which, and where do you compromise, and how do you negotiate that? It's very hard and it's very complicated. But unfortunately for shul, where we've already discussed, the singing, unless it's outside, the people, many of, the elders of our community, the pillars of our community, are the most vulnerable. And unfortunately, there's nothing we can do to change that. One of the other vulnerabilities, and this is not well understood, is men at all ages are more vulnerable than women. And even children who are rarely affected, boys are more vulnerable than girls. And again, people
don't know why. They don't know why.
Well, there are several hypotheses. Nobody knows why. The working hypothesis that seems to be accepted by the most people who I've read is that the X chromosome, so to be a female means you have 2 X chromosomes, and to be a male means you may have 1 X and 1 Y. There are many immune functions that sit on the X chromosome. So by having 2, you have redundancy, and that's what people have hypothesized. There's no real evidence for that, but it makes sense. But the observation holds true in China, in Italy, in France, in the UK, here. In China, they thought maybe it was because men smoked more. That doesn't seem to be it. And people said smoking was a risk factor. Well, it turns out smoking is not a risk factor. In fact, people who smoke are not only not getting infected more, they seem to be faring a little better, which is completely counterintuitive.
We don't want to advertise that yet.
No, we're not. Well, but maybe there are molecules, that one could be studied that could be useful, right? So that might be, a possibility. But with that said, older people are definitely at higher risk. Children are at lower risk, right?
And men, and you reminded me when you're talking about men, about the Alan King's famous comedy routine of "Survived by His Wife," which is a very famous comedy routine for those who are Alan King fans.
Yeah,
but,
no, I remember that.
For some reason, it seems to hit men more.
Right. I mean, and as the mother of 5 sons, it's frightening to me, but that is absolutely the case. So, I think, and this, one of the things that is very hard about this, and we discussed this, is many of the messages around this are very complicated, and public health messages by their very nature have to be simple. So, one of the issues is the kinds of things, particularly as we open up, the kinds of things that are reasonable for somebody in their 30s to do are not reasonable for somebody in their 70s or 80s to do. You know, it may be that, you know, the people who can go back to work are young people, and older people will need to continue to work remotely for a while. And I think that we're going to have to start to think creatively about meeting the needs of both of those groups. Children are a special case. You know, could children go to sleepaway camp? You know, again, what is the risk? Most children who get sick get a flu-like illness. Are you willing to accept the risk that your 10, 12, 13-year-old is going to get the flu and be away from you? You know, if they're in a place where they're well taken care of and they're independent kids, it might be better because they're not going to bring it home to their parents. You know, people are grappling with these ideas. People after my last session called to ask me about this, and people have to make their own decisions. Nobody has the right answer on that.
Right.
But there are, you know, again, there are ways to mitigate it. People not leaving the camp, you know, making a bubble. But how you
camp would have to be a bubble, and you'd probably have to keep the kids very separated to begin with in groups before they could be merged.
Exactly. And then, you know, and then the notion, and again, this is and this is how I like to think about these things, is what is the risk? So what's the worst thing that's going to happen if your kid goes to camp and gets COVID? Probably they're going to get a flu-like illness. You know, would you want your kid to be sick for 10 days or a week without you? Maybe it's not so bad. You know, they'll get plenty of fluids, they'll get chicken soup. But if it's a Jewish camp, they'll have a nice nurse. It's probably fine. But if you have a sensitive kid, maybe it's not. You know, again, those are very personal decisions, and they're value judgments. And, you know, the flip side of it is there's a cost to not opening, right? So there's a cost to keeping your child, as I'm keeping mine, in the apartment for the summer. Now, how serious it is, everybody has to make those judgments themselves. But, you know, those of us who have been doing online school, and with all due respect, I know the teachers have been doing making a huge effort, and they are struggling and working so hard. As Jacob says, online school is like school with none of the fun. It's really hard, and they're trying very hard. And Mr. Silvestri's done a wonderful job with his spirit and everything, but it's just super hard. And so there's a cost to that.
Yeah. So now, finally, what everyone's been waiting for. Let's do testing, antibody testing, and vaccines. So let's start with plain
Before we
testing.
do that, I was reminded by my husband very politely with a little sticky that I needed to I had neglected to mention the risk of kids bringing COVID home. So what I was talking about was kids in sleepaway camp where they're sleeping there and not bringing it home.
Right.
But if you've got kids going to school, they're probably fine. But the risk is to the teachers, to the staff in the school, and then to the parents. So, you know, in the New York City public schools, which stayed open, frankly, in my view, longer than they should have, there have been several deaths among teachers and staff, all of whom fall into the demographics are at higher risk, or not all of them, but
right, which they got it from the students.
Exactly, presumably.
Yeah.
So
let's go to testing.
Okay.
Plain up testing. Is it reliable? How reliable is it? What is it effective for us to sort of screen for? In other words, let's say in synagogue, I mean, I know the insurance companies will entitle you to one test a month. In synagogue, if you're testing people or asking people to be tested, what exactly does that tell you?
Okay, so testing is an extremely complicated topic, and it's good for many things, and it's not good for many things. So there's two kinds of tests to start with. That is a test for the virus, or a diagnostic test to find out if you have COVID at this moment. The second test is for an antibody, and that is to test if you have a protein in your blood that demonstrates that you have been exposed to COVID in the past and made an immune response. So the diagnostic test is the one that's a test of the nose or throat, and you see on the TV people getting the swab stuck, what looks like into the socket of the eye.
Yeah. Right.
And so that's the first test. And let's talk about that. So that test is super important if somebody is sick and you want to know if they have COVID. If you have a large group of people in whom COVID is circulating, say in a hospital, and you want to, test your personnel and find out who's carrying it or who might have it. One of the terrible, terrible problems with this virus is its insidious nature, and that people can carry it in their nose and throat and be completely asymptomatic for several days. And this is, again, something that's just beginning to be understood. It's clear that early on in infection, people will have, and this is very adaptive for the virus, people will be completely well without symptoms and be spreading it. Now, whether those people then go on to get sick or they never get sick depends on a whole variety of things we don't understand. Some of them never get sick, and some of them do get sick. So there is a significant amount of asymptomatic carriage. And that's what makes this different, say, from Ebola. So Ebola, you get Ebola, and within hours, you're dreadfully ill, and you really can't go anywhere.
Right,
And
SARS was the same way.
And SARS was the same way. Not quite to the degree Ebola was, but much more so. And so in those cases, screening with the temperature, for a thermometer, for an elevated temperature for fever, was a very useful thing to do. Because if people were getting sick, they had a fever. With this, for days, 3 to 5 days, people, and some people for the whole course of their illness, will never have a fever. So certainly, screening with touchless thermometers is an easy and cheap thing to do. And if somebody does have a fever, whatever the cause of the fever, whether it's COVID or something else, remember, the fall comes, all the other viruses we always have will come back. They should go home. And this is one of the things, I was like I like to look for the silver lining. I'm hoping this is going to make people realize that you need to go home when you're sick. You need not to send your child to school when they're sick. Doctors are the worst at this. We soldier on. If you don't feel well, if your temperature is over 100.4, stay home. But those are times when having the test is very useful. The problem is, if you get tested on Monday and you're negative, that tells you great things about Monday. It tells you nothing about Tuesday, and even less about Wednesday. So if you're opening shul and I come and I say, oh, look, and the turnaround time on these things is changing, and all of this is progressing. So the turnaround time had been tremendously problematic. It had been up to a week because remember,
so it told you nothing.
Right, which tells you nothing. So remember, with the testing, there's what's called the pre-analytic phase. Sorry for the jargon, but this is the scientific term, and that's the collection. And that has a whole art to it, and there's a whole issue with having enough swabs and what kind of medium it gets collected, and if it needs to be kept cold or room temperature. It then has to go to a laboratory and be tested. That's the analytic phase. And then it has to be reported. So, when they say they're testing at CVS drugstore, they're not testing at CVS drugstore. They're collecting the swab at CVS drugstore and then sending it to a lab to be tested. So there are huge challenges with the testing. It's very useful for people who are sick. It's very useful in the hospital. It's useful for populations because it's tremendously important for the state of New York and the city of New York to know what the rate of infection is. But again, that also depends on both the numerator and the denominator, how many people they're testing. So if you recall, if you look at the curves that they show, there's a day when it goes way high. Well, that's when they started to really increase testing. So now that the ratio has remained pretty stable, it's a reliable figure. But when I spoke a few weeks ago, it was less so. So the testing that as it is currently performed is done by a method called PCR, the polymerase chain reaction, which means the RNA, which is the nucleic acid in this virus, is amplified using a series of enzymes. It's a standard technique done in research laboratories and clinical laboratories all over the world. It was invented or discovered by Kary Mullis. He was awarded the Nobel Prize. He was a brilliant man. But it requires enzymes, it requires time, it's quite expensive, and ultimately it's probably not scalable to the degree that we need to do nationally. There is a test that has been developed by a company called Quidel, and I have no interest in it, I had to look it up, where they're actually testing for the protein. So they're not testing for the nucleic acid, but they're testing for the spike protein, the little, when you look at the pictures, that little knob. And that doesn't require the same complexity of technology. And they're developing it with the plan of making it like a home pregnancy test.
You get immediate, right?
Right now, it still has to, you have the pre-analytic phase and the analytic phase. But this is one of the things about which I'm optimistic. They're moving it toward what they call point of care testing. Now, I don't know how far they are. And all of these things, you asked me how valid these tests are. All of these tests have to be validated. And, you know, is a positive really a positive? Somebody asked me a question about what negative predictive value was. That means if you have a negative test, are you really negative? And so the parameters around what's positive and negative have to be set properly, and there has to be a lot of testing with positive and negative controls to set those. And in the you know, time is of the essence approach that everybody has taken appropriately to this, some of those things have not been done with the rigor with which they have been done in the past and should be done. And we're now having to go back and fix that. So 2 weeks ago, I said, you know, the Abbott test is a great test. And then it came out that a third of the Abbott tests that were positive weren't right. Well, when I told you that, the data I had was it was good.
That was the best of the time, yeah.
Right. They're fixing it. These things are improving each week. But what we're moving toward, right now we don't have it. But what we're moving toward, and I'm optimistic about, is a point of care test. And so it will be expensive. And, you know, maybe you can't ask everybody, you're not going to test everybody as they come into shul, but maybe people could test themselves in the morning and, you know.
Right, but it would still be a rapid test. I mean, it would probably only have like an 80 or 85% accuracy. You
exactly.
need a lab to validate it.
It all has to be validated, and those are complicated things to do, and they take time and they take money. Excuse me one second. One of the other things that's being developed is to avoid the swabbing, which is a misery for everybody and requires a healthcare worker to expose themselves. It requires use of personal protective equipment. Rutgers has had licensed or approved, not licensed, approved, an assay, a test where you spit into a tube. Colleagues of mine at the Rockefeller are developing it too. It turns out there's plenty of virus in the saliva. So instead of having to have this, you know, you see those long swabs put into your nose, which isn't the end of the world, but not great, you could spit into a tube. That saves the swabs, which are in short supply. It saves the personnel having to swab you, in addition to being a more pleasant and more acceptable test if people are going to be being tested regularly.
Okay, so I'm being told by Kenny I have to take questions.
Okay.
But before we do the questions, and I know two of them that actually have come up a lot in the questions, and I have no less than some 30-odd questions, 31 questions here.
Okay.
So two of them that will be coming up is give us some thoughts about antibody testing.
Okay.
And
so that's what
does it have a value? What type of value does it have, if it has a value?
So it certainly has a value. Let's start with that. It's a valuable test. Antibody testing tells you if you've been exposed to the virus. So antibody testing is tremendously useful from a public health perspective to understand how many people in an area have been exposed, where the virus has been, if people who are asymptomatic are getting it and recovering. It's tremendously valuable. For any individual, an antibody test has less value. So the first question is the test accurate? If it says it's positive, do you have an antibody? If it says it's negative, do you? That's the first question. And there's been, you know, that's going to get worked out. I don't want to spend time on the vagaries of that right now. For right now, it's still not entirely correct, but it's getting worked out. And the way those tests are being set, if it tells you you have an antibody, it will be right. And maybe there will be people who do have one and it won't detect it, and that's probably okay. So that's what's, you know, that's how the parameters of these tests are being set. So this is the problem. What does it mean about immunity? And you'll hear people say, we don't, you know, immunity's not going to last. We don't know about this. You know, we don't know what it means. It may not mean that you won't get sick again. And all of this is based on the fact that we just don't know. and people are conjecturing from other coronaviruses. So there are coronaviruses, there's an A group, which is the group that causes a common cold. About 25% of when you just have a sniffles, it's caused by a coronavirus. The B group is SARS, MERS, and this SARS-CoV-2. Much more is known. There are people who've been studying the A group for longer than I've been working on HIV. And one of the problems is we get colds over and over again. We don't develop what's called sterilizing protection. But we don't get terribly sick either. So it may be, and there's evidence that pre-existing infection with other coronaviruses may confer some level of protection. So understanding who's protected and who's not is a huge open question. Simply having a positive antibody means you've been exposed to the virus and your body has made a response. You cannot from that conclude that you are protected. The great likelihood is you're probably more protected than you were without the antibody, but we don't know what level of protection that is. And that's why people are being so
people
cautious.
could be reckless based on that test. In
Right,
other words,
exactly.
The antibody test may give you a little bit of comfort, but as you and I were talking about this whole idea of the Peltzman effect, which is something that was studied in cars, where they put in safety belts and people would drive more recklessly because they knew that they had a new safety device, and actually their danger went up. And you spoke about it in terms of behavioral enhancement.
Right, so behavioral enhancement in vaccine development.
Right, and here, the issue is of course, if you get a positive antibody test, it may be misunderstood, and that I imagine is the issue.
That is for sure the issue, and this notion that people were going to have immunity passports, that if you had an antibody, you would be immune and you could go back. That's a fiction. As I said earlier, if you've been sick, if you have the right clinical history and you recover, you likely are protected for some period of time, and you're not going to get sick again. And why I say that is people who work in a healthcare setting who got sick, recovered, and are being tested over and over again aren't getting sick again, but some of them are testing positive again. And what that positive testing means is a very important open question. So some of the time it probably just means there's some dead virus left over and it's a PCR assay, which is extremely sensitive. But some of the time what it might mean, and this is data from that's substantiated by other coronaviruses, is that even though the person who has the virus, who got sick, got better, has an antibody, got re-exposed, they can carry the virus in their nose and spread it to others, even though they themselves are not going to get sick. So what that means is even if you've been sick and gotten better, you probably aren't going to get sick again right now. We don't know if it's 3 months, if it's 6 months, if it's a year, but you could still spread it to others. So what that means is that everybody needs to wear a mask. And, and this is what we talked about. And I think that we have done ourselves a disservice with the messaging around mask wearing, that it's only if you can't socially distance. I think wearing a mask is really critical. It's probably the single thing you can do to protect yourself and your family and others. And, so if you've gotten it and you've recovered, if you get exposed and it grows in your nose, you're not going to make somebody else sick, even if you yourself would not get sick.
So let me move to the final thing, and we have no less than 30 questions. So I'm going to try to take a few of them, but just give us an update on vaccines. We spoke about it, I think it was 2 weeks ago when we met.
Right.
Give us an update. Is there anything new in the last 2 weeks that's been fascinating?
I have to tell you, Rabbi, I could talk for several hours about what's happened in the last 2 weeks in vaccines, but I won't. I might hear, but you guys don't have to listen. It's a remarkable thing how much effort is going on and how much progress is being made. There are over 100 vaccine candidates in the pipeline, which I've never heard of that. And a vaccine candidate is something that's being tested. A vaccine is actually something that's licensed. So they're all candidates right now. I think 5 have entered clinical trials in humans. It may be 6 by now. A few the Moderna vaccine, which I want to speak about because I think it's very interesting, which is an RNA vaccine, the Oxford vaccine, which is with AstraZeneca, which is a viral vector vaccine, and then 3 in China, with which I'm less familiar. The Gates Foundation and the US government with Project Warp Speed are doing something very smart. And so these vaccines are being developed, they're being worked on in the lab, they're being tested preclinically in animals. Very fortunately, unlike HIV, this is a virus which is a good target for a vaccine. And if you want me to come back sometime, I can talk about why that is, but I'm going to skip it for now. But let's be very grateful for that. It's not clear which of these candidates is going to be best, because developing a vaccine is a rocky road and most of them fail. So it's good we've got a lot of opportunities, a lot of shots on goal, as they say. But one of the challenges, which happened with the polio vaccine, as we talked about, and I sent the article that talks about this, is the polio vaccine was tested, it worked, and there was no plan for making it. And we don't want to have that happen. We don't want to have a vaccine and then have to wait 1.5 years to make it. So both the Gates Foundation and the United States government are moving forward with manufacturing capacity, which is a non-trivial effort, in a way that's called at risk, which means they're developing the factories, they're getting all the things together, and then they'll just decide at some point which of the candidates will go into these factories. It's very hard to do this because each of the different candidates has different things it needs. Right now, one of the big issues is having enough glass vials. You know, I mean, there just isn't that much need for glass vials, and a lot of it's been outsourced, and now there's a huge effort to make the appropriate kind of glass vials. Rubber stoppers. I mean, these things sound mundane.
You need billions of glass vials.
Exactly. And so these sound like the mundane, but they are, it's like the swabs for testing. You can't do more testing. I mean, people have been clever and now are developing the saliva tests, but these are practical problems that have to be addressed in the here and now. So again, as I said, both Operation Warp Speed and the Gates Foundation are developing these manufacturing capacity at what's called at risk, and that's wonderful. Vaccines take a long time to make, some of them, particularly the viral vectored ones, because they're complicated technically. The Moderna vaccine, which entered clinical trials already and is...
It's phase 2.
Right, it's in phase 2, and the data from only 8 people was released. 45 people received the vaccine, but they released the data on 8 because they'd gotten far enough along to have the data. Because the last time we talked, I was like not sure why they'd only released 8 people, but the paper came out and it's because they were the first 8 to get it. Looks like it's inducing the kind of response people think we need, which is wonderful. And that is an RNA vaccine. So no vaccine made from RNA has ever been licensed. I believe there are 2 licensed DNA vaccines for humans, and there are some veterinary vaccines that are made of DNA. I don't think there are any licensed RNA vaccines as far as I've read. But if it works, it's easy to make and it's quick. So that could be available by the winter. And so as we were talking, it may be that gets deployed, and I don't know how durable that immunity is going to be. It's quite reasonable to think the viral vector vaccines may induce more durable immunity, but they could be given subsequent to that. That's what happened with the polio vaccine. It's called a prime boost strategy, where you give one vaccine and then it's followed by a subsequent vaccine for the same pathogen, but it's a different kind of vaccine. So if the Moderna vaccine works, maybe it works well enough that that's the ultimate vaccine. I mean, that would be, pardon the expression, a godsend. I mean, a Metsia, that would be wonderful, but we can't count on that. But it will almost certainly be the one that's available first. So even if it provides some level of protection, that will be better than nothing. If
it gives you 1 year of time, it's
right.
Amazing.
Right, and so, we talked about the issue of partial protection, which means it protects people partially. It protects some percentage of the population. Typically, vaccines need to protect more than 90% of the population to be licensed. But if it protected 70, I think we would all be delighted. Or it only provides partial protection, and that means protection from severe disease and death. Even if it didn't protect from mild disease, that would be okay too. So all of these scenarios are possibilities, and I'm optimistic that, that we'll at least get something like that.
That's wonderful. Okay, so I'm going to move on. There's a lot of questions. I see there's 30 questions. I'm going to take one, which I think is of great concern, particularly to our parent body, and that is multi-system inflammatory syndrome in the children, and also the pseudo Kawasaki syndrome. So in other words, this is something that the multi-system inflammatory syndrome affects teens, and certainly within our community we've had that, and the Kawasaki. Tell us what you know about that, and what would be your response?
Right. So this is some of the worst news that has come out in the last, I don't know if it's the last month or 6 weeks. So early on, it seemed that children were really not affected by this disease. There were a few exceptions, but they were children who had severe underlying other conditions. And in the last, I don't know, 6 weeks, it could be 8 weeks. Again, I'm not so good on the time. This condition called multi-system inflammatory syndrome has been noticed, and it's terrible. It's an inflammation of the blood vessels in children. Only about 2/3 or 3/4 of the children who have it have evidence of exposure to COVID, either a positive test or a positive antibody. But since it is over half, it's been associated with it, and it's been seen not only now in the US, but it's been seen in Italy and in France and other places in Europe. So it's thought to be associated. It's very rare. The good news is if treated early, it's treatable. Kawasaki's syndrome is also treatable.
What the treatments are generally what are the treatments?
They're anti-inflammatory. You know, I don't want to say the wrong thing. I don't know. They're anti-inflammatory treatments. A lot of it is supportive care. It's ICU care. It's fluids and you know, all of the sort of emergent ICU care. Fortunately, I think most, if not all, of the children have survived. But it's a, you know, sort of a catastrophic thing, because the one saving grace, it seemed to me, of this virus is we didn't have, unlike, you know, influenza, which was killing children in preference to other people, children seem to be spared completely. They're still relatively spared. They're not getting the respiratory pneumonia kind of complications that we see in adults and older people. But this is a new phenomenon, and it's being very carefully watched. You know, as a physician, I get alerts about it all the time. You know, people, the signs are fever, a red rash, and a stomach ache. And if your children show any of those things, get medical attention sooner rather than later, because it affects the blood vessels, particularly those from and to the heart. And you want to get the inflammation taken care of right away. On a more positive note, a colleague of mine at the Rockefeller, Jean-Laurent Casanova, is an expert in the interrelationship of infectious disease and genetics. And he's been studying Kawasaki's disease for the last 20 years. And he's engaged. Actually, I was so excited because the governor mentioned it and it was on one of his slides. He's working on trying to figure out if there's a particular genetic predilection to this, which would be very good to know, because if you could know that, then you would know who you had to be watching out.
People can reach out to you directly to pose these questions and
sure.
discuss them with you.
Yep, absolutely. I've tried my best to answer everybody's question, but it's a lot, and as you know, I'm working, so I'll do my best to get to everybody.
Okay, and whatever, I'll make sure. And so we've got 30 questions, but it's 9:11, and I see Kenny coming back on screen. So that Kenny is sort of like the guy who says, "Okay, it's over."
Yeah, I was just going to say, I can talk a long time, but
no, it's not over. I want to say that I don't want to take too much advantage.
This for a little bit later. I'm going to let Kenny jump in, but Sarah, I just wanted to thank you.
No, I think it would be great if Dr. Sarah would take, Dr. Sarah, could you ask just one more question? I think we're good just for, you know, one question. Does that work for you?
Go ahead. Or you want me to pick the question?
No, Rabbi, please pick the question.
I see one about steaming. Does steaming kill the virus?
Steaming?
Yeah, like hot steam.
Hot steam, heat kills the virus. I think it depends how long and how hot. So one of the things that I thought was really clever is the police people are very worried about the police cars being, you know, because they bring all kinds of people in them. So apparently a lot of the New York City police cars are Fords, And so a very clever group of engineers at Ford figured out how to put a hot cycle into the heat. And they have all these safety features. They have nobody can be in it. They have to push several buttons, but it's like automatically cleaning your oven. That the heat will heat up the car. I think it's to 130 degrees for 15 minutes, and that's sufficient to kill all the viruses.
No kidding.
No.
Wow.
Isn't that clever?
That's unbelievable.
I think
that's really unbelievable.
Just so clever. So yes, steam, if you got it hot enough, yes, it would. I don't think you can get in steam, like, a steam room, like a sauna. I don't know. I don't know how long and how hot it would have to be, but in principle, yes. But again, the devil is in the details with all of these things.
Right. I think we're going to leave it there because we've got so many questions. Like, can we fly to Israel? What is happening in Israel in terms of the restart? Can we have guests for dinner? Oh, these are like so many questions. I think what we'll do, Kenny, and we probably should wrap it up. Is just maybe put. I know that you've been kind enough to offer your email address in the past.
Sure.
So maybe we can share that in the chat for those who want it. Is that okay?
Sure, that's fine.
Okay.
But just know that it might take me a little while. I don't want to disappoint you.
Yes, what we will actually do, Rabbi, which is what we did the last time. We can actually mail emails, since we have the people that logged on, all of their emails. We can actually email everyone and share, because you had some articles also that you mentioned, the links to the articles, and give at the same time
we do that.
Your email
that's a better way of doing it. That's a better way of doing it.
The other thing, the one thing I'd like to say, because I got questions the last time about, like, can we go to Florida? Can my kid go to summer camp? There's no right answer. All of these are very personal decisions. And it's what I said earlier about a risk analysis. If you're otherwise healthy and, under a certain age, sure, the risk is probably pretty small. Wear a mask, wear gloves, wash your hands, bring Lysol. Flying, travel and flying, it was a whole other discussion. And frankly, I'm not expert on it. It worries me terribly, but I believe it can be done safely. But I think that's one of those things that's going to be, in my view, farther down the road. People ask about the theater. I mean, the theater is like shul. I think that's going to be a really hard one.
Right.
What's happening in Israel, that's also another topic. I know that, things have gone very well there, but they've had, with opening up, as they have in other places, there's a spike, and there was a super spreader event that I read about. Oof. And when one of those things happens, it's bad, but things are progressing. I will tell you that my aunt sent me a link to a test that was being developed in Israel, where it was like a breathalyzer, a device that so it brought that pre-analytic and analytic phase together, like a home pregnancy test, like a device you blew into, and you'd get a colorimetric, a color that you could see. And I don't know anything about the company, and I thought that was really cool. So, I think those are the kinds of things that are going to really help us until we get that vaccine or treatment. Well,
Dr. Schlesinger, Hirschfeld, and
Please
Rabbi Steinmetz, thank you for this has been an amazing evening. The comments and the feedback that we are already getting again about this evening, and asking for yet again another evening, another Zoom opportunity with your clarity and the knowledge. It's just, I have to tell you, it's very comforting for many of us. On the one hand, it's a difficult topic, but on the other hand, you really give us tremendous amount of information in such a clear way. So thank you. Thank you, Rabbi Steinmetz, for your continued moderating of these pieces. And I just want to remind everybody that our Zooms continue. We have some wonderful programs up and coming. We will be sending out emails about them. We do record all of our Zooms, and they are available to you and to your family to send forward to others. I know people ask all the time, can I share this? Please, when you see the Zooms, you can go right onto the site that we have, and please, you can share them. We're happy to have them shared. And there are opportunities for sponsorship of these Zooms. We do ask for people to support the things that we are doing. We will continue throughout the summer to have educational opportunities for our community, for for the Ramaz KJ community. So please be in touch with us. We've taken ideas from you. If you have further ideas or people that you'd like to see on here, please don't hesitate to be in touch with us. Thank you all for joining us. Please stay safe and healthy. And we just, again, wish everybody only good things, happiness, and all of you, have a great night. Take good care.
Good night,
Night.
everybody.
Thank
Good
you.
night.
Good night.